Contoura LASIK and overview. So we all are aware of the different ablation profiles based on which different types of LASIK have evolved over a period of time, starting from standard LASIK to wavefront guided, wavefront optimized, topo guided, and now with the newer development in ray tracing technology in the form of Wavelight Plus. All with a single aim to provide patients a vision as close to perfect as possible. Before studying the different ablation profiles, we should know what is sphericity of the cornea. It actually determines the shape of the refractive surface. After we do a hyperopic LASIK, we are changing the Q value to more negative and inducing more spherical aberrations in the eye. And after we do a myopic LASIK, we are making the Q value positive and inducing more positive spherical aberrations in the eye. The standard LASIK or the conventional ablation profiles used to induce a lot of spherical aberration post-surgery, which resulted in visual problems, especially the night vision problems in the form of glare and halo. Then came technologies like wavefront guided, which were designed to correct all the aberrations of the eye, but an ideal candidate was a one with higher order aberrations more than 0.3. Then came wavefront optimized, which actually did not correct the pre-existing aberrations but prevented induction of newer aberrations by giving additional laser pulses in the periphery. Then came the concept of Contoura. We all know that cornea forms the anterior 2/3 surface of the eye and is the major refracting surface. So correcting the irregularities of this surface was desirable to achieve optimal outcomes. It all began as a topo-guided treatment for irregular eyes, for keratoconus eyes, for smaller decentration ablation, and for smaller ablation zones. So it was essentially a repair tool which was meant to improve the BCVA rather than the UCVA. And then how was Contoura born? So FDA actually, for giving approval for treatment in irregular eyes, wanted a study by the company to be conducted on virgin eyes. And this study showed a remarkably better vision in Contoura eyes as compared to WFO. And this is how Contoura was actually born. So this is the study which stated that the eyes performed with Contoura, virgin eyes, actually gave a better result. 40% of them resulted in gain of 1 line at a period of 12 months. And subjectively, patients were very happy because the incidence of glares and halos was much lower as compared to the previous technologies. So how is Contoura different from WFO? WFO treated just the refractive error based on the prescription and the K readings, whereas Contoura, along with refractive error, treated the irregularities and the aberrations of the anterior corneal surface as well. And how is it different from wavefront guided? So wavefront guided treated the ocular aberrations entirely, and Contoura treated just the anterior corneal surface. But wavefront guided did not prevent induction of new aberrations and was treated along the pupillary center rather than the corneal vertex. Also, the removal of tissue was a lot more in wavefront guided as compared to Contoura because of the bimodal ablation approach of Contoura. So the salient features of Contoura are it uses an Allegro topolizer vario, which is a Placido-based device. It is designed to correct HOAs. It provides centration and cyclotorsion compensation and primarily was introduced as a repair tool. So data is acquired from Allegro topolizer vario, which via WaveNet server is transferred to the planning station and finally to the Wavelight 500 in OT. The first map shows us the manifest refraction ablation profile, plus the second map shows us the higher order aberrations of Contoura. When combined together, they give us the treatment plan, which closely resembles that of manifest refraction. There are certain pros that it is a well-known technology to improve visual acuity, is not biased by accommodation, and is not pupil dependent. Whereas one of the cons of the technology is it requires a time and a lot of training for proper scans, because garbage in is garbage out. So if scans are not proper, we will not get optimal results. And there are several studies in the literature, contralateral eye studies, in which one eye was done with Contoura and other eye was either with wavefront optimized or wavefront guided. All of them showed similar results in terms of visual acuity, with Contoura eyes achieving 1 line extra as compared to the wavefront optimized, But in terms of quality of vision, the contour eyes perform better. So, first step comes to proper scanning. Here is a short video courtesy
In order to generate good outcomes in contour surgery, it is important to begin with the acquisition of good scans. How do we ensure this? Make sure the patient is sitting in an upright and comfortable position. Have the patient place his or her chin into the chin rest and have his or her forehead properly positioned in the headrest. In case of a deep socket, the patient is requested to place their chin over the railing.
Volume little up, please.
Advise the patient before blinking to avoid breakup of the tear film. Fixation target for good measurements.
Voice, please. Voice.
Ensure that the preferred registration and analyzed
So we have to
area
check for
indicators
preferred,
are
registered
all
and
green
analyzed
so as to
area
signify
to
good
assure
acquisition
that the scan
quality.
is proper.
Red is indicative of a scan unsuitable for cyclodortion compensation. The optical zone analysis should also have a green check mark to indicate good quality of scan. While selecting scans for export, it is important to evaluate each individual scan and assess the pupil diameter. Ideally, the pupil diameter should be within 0.5 to 1 mm of the diameter displayed on pupillometry. Label the ideal scans for easy export. Larger pupil diameters are preferably avoided. Comparing the selected scans for regularity is also an essential component of the process. Scans are selected for comparison and the difference in curvature between two scans is measured. It should ideally be equal to or less than plus or minus 0.75. Scans with differences in curvature amounting to greater than 0.75 are excluded from the dataset. The scans thus selected are then exported for planning. You may select any 4 scans with the smallest available pupil diameter in the dataset for planning. How does this affect the outcomes? Our first scenario shows prompt pupil recognition intraoperatively for effective cyclotorsion compensation, which is a crucial aspect of topography-guided surgery. This was possible as the difference in pupil diameters was less than 0.5 mm. A cyclorotation of 2.5 degrees was detected and accounted for during excimer laser correction. In the second scenario, there is failure of registration. This will lead to lack of compensation for cyclotorsion, translating to suboptimal outcomes. In such a case, one can repeat the measurement. It would also be helpful to turn off the patient fixation light and focus diode to aid pupil recognition and cyclotorsion compensation. Our third case shows a significant difference in the intraoperative pupil diameter and the one scanned on the topalizer. In this case, registration is needed to be turned off manually in order to begin the excimer laser treatment. One needs to be aware that this may lead to suboptimal visual outcomes due to undercorrection of astigmatism. Incorporating good scan acquisition practices would be invaluable in ensuring great patient outcomes.
So after proper scan acquisition comes proper planning, for which the first step is selection of proper images. Based on the registration symbol, based on green tick, K values and pupil diameter, we can select the best 4 scans. And also we need to check the median absolute deviation, which is the last value at the bottom of screen. It should be as close to 0 as possible. Then we enter the patient's manifest refraction and vertex diameter is 12. Then we check for the 0-0 ablation, and we can also check for Zerny case. And After checking the zero ablation, now is the time for decision making. So we have two values with us, patient's manifest refraction and the measured topolyzer cylinder and axis. If both the values are similar, it's very easy, we can go ahead with treatment. But if the values are dissimilar, we have a clinical dilemma. To solve this, there are multiple strategies, starting from the patient's manifest refraction, which was initially followed, but the results were not that optimal, and because of the suboptimal results came the concept of topography modified refraction developed by Dr. Kanellopoulos. But again, some of the papers stated that it overcorrected cylinder, resulted in flipping of the axis, or sometimes residual cylinder. So then came the concept of modified TMR, which is somewhere between the manifest and the measured power. This is the algorithm given by the company which we can follow. It treats somewhere between the manifest and the measured cylinder with the aim of keeping the spherical equivalent similar to the manifest refraction. Also, a software developed by Narayan Nethralaya, 3Z software, which focuses on Zernike's pyramid zero rule and the lens. Considering all the three things, they have divided the patient into three groups, and this software actually tells us whether to do Contura or not, or to go for wavefront optimized, and if yes, if we have to do Contura, what refraction should we enter?
So if we can go back one more thing, because this was 2-3 people had asked this question, is the group 3 patients, when your cylinder is more than the measured cylinders, is this group is your red flag, because these are the people who are going to be very, very unhappy if you, whether you do, because that means that there is a certain amount of accommodative tone, which we call psychologically, in a very calm, peaceful person versus a very stressed person. This is what we have observed in school kids. Excessive parental pressure and all. If you do their accommodative tone, the tone of accommodation in a child who's been pressurized is completely different compared to this. In this whole group, compared to each one of us have our own personality. If you just go and do our own accommodative tone on, say, on your eye trace or on a thing, it's going to be completely different. So the tone in the group 3 is where your cylinder, what you subjectively doing, what you just ask, is completely different. You can treat him as WFO, no problem. But remember one thing, he's the one who may come back to you after some time saying that I have a regression, my power is not stable, I see glare at night, I am not happy with it. Then you go back and check, even 99% of the time you'll see that is the same guy who had it. So what you do in these people is, they have something called as accommodative excess, most of them, because their accommodative tone. So that means when you are stressed, what happens? Your whole body goes into some kind of a spasm, and your the response it's a fright response. There are areas in your brain like hippocampus, anterior cingulate gyrus. All these things are for the evolutionarily they are responsible for running when you see an animal when you were prehistoric thing. They were all the same conditioning happened. So when you are in that stress mode, every part of your muscle goes into that state, and that is when your lens starts becoming more defocused. But in this patients, it's not the defocus from a spherical point of view, it is a defocus from a cylindrical point of view. That is, your accommodation is not in a normal way. So this group of people, after surgery, just send them to your optometrist and just check your NPC, NPA, just a routine thing. You'll see he's accommodating more. Or on your day 1, you do your auto ref, he'll be reading 6.6, but it will be -1 cylinder, one spherical or cylinder. You know this is guy who's going to be unnecessarily. So within the first 2 or 3 days, make sure that you give him an accommodative exercises to reduce his accommodation, and also tell him that if he's, it's going to induce a pseudo myopic shift. But if you don't treat him, after 6 months, 1 year, the same people have a crossover in your limbic system, because interestingly, the area of the brain which is responsible for your visual, we call it as visuals, it's called the spatial recognition. Spatial recognition is I'm talking on the mic, but I know Aarti's hand is coming for the cup. So that means I'm aware that if I move my hand, it will spill on a beautiful sari. That is what we call it as a spatial recognition. Kids who don't have spatial recognition are the ones who end up in issues in school, and they become a trait as you grow up. That means you are not aware that there is something which can spill over. So what happens is the area of your brain, the prefrontal cortex and those the amygdalas, so the anterior cincinnate gyrus, the posterior cincinnate gyrus, all also are responsible for the spatial orientation. And unfortunately, that's the area for your behavior also. So that means people who have extremely negative and the type A behavior are also psychologically driven by these areas, and they also have the same area which is responsible for the spatial. Like I do like this without knowing who is sitting. That means you are completely aware of it. So what happens is your accommodation is responsible for the spatial awareness. That means if my accommodation is based on how my spatially aware I am. So it's very important to understand that your behavior in a very anxious patient leads to, I think Dr. Wavikar and me have managed many co-managed. We always used to wonder why the patients who are very anxious ends up in a very vague accommodation. It's because the behavior of them and the spatial recognition centers are very close by. And there is something in psychology and neurology called maladaptive neuroplasticity. That means your one area of brain, excessively if it is stimulating, it spills to the second area. It's like the cup filling over. So that means the excess stimulation of astrocytes and microglia moves to the next area of your brain, which is supposed to balance your spatial orientation and an accommodation. So the person who is anxious ends up in having more accommodative issues, and he becomes a big pain to everybody. I thought we are the ones we're having. The day I was in Delhi, Professor Tityal sir was telling me, Rohit, I'm sending somebody. I said, sir, if they can bother you, then I think everybody else is. I think we have very small. Imagine at that level they can bother. That's what I tell my young fellows. Refractive surgery looks like magic, but one patient can bother Professor Tityal or one patient can bother Maipal. I handle both their patients. It's not possible to. It's very difficult. Then for that you will have to start looking at it. So that's why the first thing you do when you see a -1 or a 1.5 cylinder on your auto ref means he is one of those characters. For the first thing is to send him to an optometrist. I don't tell him orthoptics and all. I said, you need physiotherapy for your eye. And I put it in my consent form. Everybody needs physiotherapy of the eye after surgery, because any surgery you do on a human body today, you need physiotherapy. You do a hip replacement, you need physiotherapy. And that will help them tremendously in avoiding. This is one of the major reasons a lot of doctors don't want to do it, because they don't know these outcomes. For them, every outcome happening thinks that it's happening from your optical system. Here, optical system has no role. That is why that subjective and this axis doesn't match. Absolutely. Absolutely. Without you telling, I can picturize that face. And how, because we see it so often. And our fellows are laughing. They are the ones who see most of my posts. It's so common.
So I just wanted to ask one question. I think it will be very relevant over here. Like we were just discussing, if the manifest refraction, rather cylinder or refraction, is not corresponding to the subjective refraction, especially when we are not overcorrecting, but maybe doing a correction in between. Sometimes, maybe in later, after 3 months, 4 months, the patient may be fine, but immediately post-surgery, they start complaining, especially with high myopes, that I'm able to see everything far away, but I'm not clear, my vision is not clear for reading for my computer. So they are kind of very stressed. Of course, maybe like we were just discussing, after 6 months, they'll become emetropic and they'll be absolutely fine because we'll be giving them accommodation, exercises and physiotherapy of the eye. But immediately post-op, how to tackle such patients, sir? Especially high myopes, I have seen them, that they do complain.
We had a very bad case, what he was referring to. Like one of my patients, one day post-surgery, she was absolutely fine. And 7 days later, like it was a havoc. And she had lots of orthoptic evaluation problems. So we started doing orthoptic evaluation in all LASIK patients pre-operatively. And we get at least one patient every 6 months. If we had operated without giving proper exercises, this fellow would have been on my neck.
But one thing you can do is, if you don't have the time or people to do it, put it in your consent or explain to them. You may need physiotherapy after surgery, which is part and parcel. When you put it into their brain, you are 90% you have avoided the risk. Because if you don't tell them and you just send them to an orthoptics, they will say that you have done something wrong. And one thing you have to tell is that, see, you may need it. And so you all the take home today is how you put it into your explaining. And my counselors will not talk about anything else other than this in the initial part of it. There's a misalignment, and especially when you have those extremely now you can go back and understand why extremely anxious and stressful patients end up in poor accommodation. That's because their pathway in the brain is very, very similar.
Rohit sir.
Probably in high myopics, the accommodation is less because they are not used to a normal accommodation. So I tell my all patients that initial days you are not able to see so clearly, start seeing from distance. So gradually over the month, they develop the accommodation and probably they are comfortable.
Sir, a point very rightly put. The same thing I also explain my patients, that when you are myopic.
Yes, explain them that you are not, I myself positively explain them that you are not able to, so before they complain.
And what is interesting here, this doesn't stop with this. The entire dysphotopsia and all these things, there's only 10% in what is considered as true dysphotopsia, only 10% is true dysphotopsia, because 90% is convergence insufficiency. Convergence insufficiency is not as easy to pick up like an accommodative insufficiency. If you do a good convergence testing on them, you will see every multifocal patient who complains has convergence insufficiency. Indian and people are just extrapolating those angle kappa, angle alpha in a pupil of 2 millimeters. How much of angle kappa thing will work in Indian eyes? Nothing. And our brain is so beautiful that you have an angle kappa of say 12 degrees, it just neuroadapts. What they can't neuroadapt is an optical system with the poor convergence. Your positive fusion vergence is so bad in that they just cannot fuse. When they can't fuse, there are two optics. The fusion is an issue and your multifocal is an issue. And that's it. So dysphotopsia has been, and all that dysphotopsia is great, but I've at least had 3 people who had tremendously bad dysphotopsia. Within a 10 days vision therapy, they improved by 40%. How can dysphotopsia improve by 10%? The other thing is, which can work like placebo, which works wonderfully well, there are drugs which increase serotonin. Serotonin is necessary for the areas because that's a limbic system. Because serotonin and non-epinephrine blocks the unwanted thoughts. That's why when you feel happy, the serotonin blocks your unhappiness. That's the basis of all the meditation, what it is. So what I tell them is, in scientific literature, resveratrol, omega-3, and to some extent curcumin helps in reducing the maladaptive neuroplasticity. maladaptive neuroplasticity is the GABA neurons moving to the other centers to excite them. So there's nothing work like magic. And if he types, you type it on ChatGPT now, and set role of resveratrol and in what is that curcumin in reducing central sensitization of this, you will get that they have multiple roles. So the patients will feel that you're given them a tablet which will work well, and please start it for all your dysphotopsia, glare, gill and all. I tell them, and what works well is placebo. And there are beautiful articles which say that you give the patient an injection of water showing the bottle as morphine. When World War II, when they didn't have morphine, all the soldiers they had put a bottle as morphine and they were giving injection of water. And what surprised them is, it was a National Geographic, the title was The Faith and Healing. The healing of pain worked exactly the same when morphine was shown and given. So I tell my patients, I'm going to give you a starter treatment. It has a component of resveratrol in it, and it will reduce, and you should use complex words, which should not register in their brain. And it works wonders. Natasha was checking, you can see it's there.
Rohit sir, this also happens very much with the cataract patients when we are putting the higher end intraocular lenses like IDOS. One of a patient is giving me a lot of pain now, and she has got the best possible vision. We have done all kind of investigations with her, macular OCT, everything. So I think that is the anxiety part, and what you.
So what you do is you check for convergence.
Okay.
And now anyway they're doing it for a lot of their patients. You look if the convergence is insufficient, start them on therapy. Okay. And start him on high dose of this resveratrol or one of those things, and tell him that it will help you in maladaptive neuroplasticity. You just see after 2 months he will come back and say 20% better.
Okay, sir. Thank you.
Serotonin and norepinephrine, there are a lot of this serotonin reuptake inhibitors, but it makes you very, very dull and moody. So you don't need to work on it. But what can increase is through all this natural component which can increase.
So 4CDs is again one more analytic software which helps us in giving what type of refraction to treat and whether to do contour or not. Thank you.
Thank you, Dr. Palak. I would now like to invite Dr. Chandrashekhar Wavikar, sir.
What's the difference between contour vision and...
Very same. The names are different. It's like Dolo, but different names.
So he has got a machine.
Resveratrol is a natural compound found in foods like red grapes, berries, and peanuts. It's been studied for its potential neuroprotective effects, and it's believed to support neuroplasticity in a few ways. For example, it can reduce inflammation and oxidative stress in the brain, which helps protect neurons. It may also enhance the growth of new neurons and strengthen synaptic connections, ultimately promoting cognitive function and memory. So it's definitely an exciting area of research.
Even if they read, this is exactly what he's going to listen to.
Now we are thrilled